Yeah, I think we're going to get started. Welcome, everyone. This is the Burlington County chapter of the Federation of Democratic Women, and we are honored and privileged to host Crystal Charley-Sibley and Jamie Agunsday talking about maternal mortality, which is something that I only recently learned to be an issue. So I think it's important because if I didn't know, I'm sure there's a lot more people that don't know about it. And it's important that we pay attention and then we find out more and find out what we can do about it. So I'd like to welcome Jamie. Jamie is, I'm going to read the bios for you. Jamie has been serving women and their families in South Jersey for the last 6.5 years as a labor and delivery nurse after graduating from Rutgers School of Nursing in Camden. She's a maternal child health advocate whose areas of interest include raising awareness of maternal mortality and morbidity, improving outcomes through decreasing use of unnecessary cesarean birth, and creating environments of respectful maternity care. She serves other New Jersey nurses as a member of the leadership team of her professional organization and is a trainer and mentor to new nurses. Jamie is a nearly lifelong resident of Burlington County, where she is now proudly raising her family. Welcome, Jamie.
Thank you.
And Crystal Charley-Sibley is a proud wife and mother and the immediate past president of the Southern Burlington County branch of the NAACP and continues to serve the branch as the Women in NAACP chair. Sorry about that. She is the director of Black Health Equity for Salvation and Social Justice. It is with the salvation and social justice and the intersectionality of Crystal's passion and skill sets manifest to move the needle towards liberation for Black people in healthcare spaces. She is a patient advocate for Black maternal health and healthcare equity and founder and CEO of the Melanin and Motherhood, where she advocates for policies and legislation that will eliminate the disparities in Black maternal health that result in high Black maternal morbidity, mortality, preterm birth, and Black infant mortality. Crystal is also a prenatal and postpartum doula. Welcome, ladies. I'm so happy to have you here. And let's get started. Jamie.
Thank you. Well, hi, everybody. And I wanted to say thank you so much for having me here tonight. I'm so honored to not only, be a nurse in the state of New Jersey and to serve the families in our state, but to be here tonight to share with you some information about some things we can maybe do to improve maternity care and healthcare for women in New Jersey, especially during Women's History Month and coming off of Black History Month. So I think it's really important to raise awareness about this, and I'm so honored to be here. And I'm honored to be here with Crystal and to hear more about her amazing work. I'm as much of a spectator tonight as I am a speaker. So before we get started, I think it's really important when we talk about maternal mortality to always start with a brief moment of silence. And the purpose of doing this is to remember and center the women who have died, whose stories that we're going to talk about, that we are going to learn from, but for some whose names and faces we might never know. And then to also, use this this time to hold space for the survivors who have had to learn to live without their loved ones. So if we could just take a brief moment just to center everything on these families and these women, I feel like that would be a good place to start. Thank you for that. Let's get started. Let's get to work. So one of the things that I found really shocking when I started learning about maternal mortality as a nurse was when I heard that America is the most dangerous place in the developed world to have a baby. And that's really shocking. And New Jersey is, one of the states that needs a lot of improvement when it comes to maternal health care. So some of the things I'm going to talk about tonight are just to set a baseline for where we are in maternal health care in the United States and kind of how we got to where we are right now in talking about all of this. So the first thing I think it's really important to do is to define what maternal mortality is. You know, you hear people talk about it. Well, what is maternal mortality? So it'll kind of set the stage a little bit because there are a lot of different definitions that are used, not only when we're speaking about it, but that are used by different agencies that collect data and do reports on maternal mortality. So to make like a working definition of it, that's not too wonky, I'm going to talk a little bit about how we would define a maternal mortality. So maternal mortality is when a person dies while they're pregnant or in the year after their pregnancy ends. And we talk about maternal mortality in terms of women, right? Because women are the child bearers. But in order to be inclusive, you know, a lot of the new terminology that we're using, we want to make sure that's inclusive. So you'll hear a lot of people say, you know, women and birthing people. So I might kind of go back and forth and refer to women and birthing people. So maternal mortality is when a person dies while they're pregnant or in the year after their pregnancy ends. And to make it kind of broad, you know, that pregnancy might not necessarily end in a live birth of a living baby, right? It might be somebody who has a stillbirth, who has an early pregnancy loss or a miscarriage, or somebody who has a termination of their pregnancy. So all of those people who were pregnant over, you know, in time and had a pregnancy end, we measure maternal mortality for a pretty good long, you know, time frame. For somebody who gave birth to a full-term baby, we look at their whole pregnancy and then the year up until after they die. So when we look at maternal mortality, we look at two things. We look at pregnancy-related death and we look at pregnancy-associated death. If a person dies of something that was caused by their pregnancy, something that was a complication of the pregnancy, or something like a health condition that was made worse by their pregnancy, it's a pregnancy-related death. If they die of something else while they were pregnant, like a car crash or a drug overdose, while they were pregnant or in that year after they die, that's considered a pregnancy-associated death. So you'll hear some of the statistics reported a little bit differently. People talk a lot about the high rate of pregnancy-related or pregnancy-associated death in New Jersey. And that's because they're talking about the pregnancy-associated rate. So you're going to have this like large umbrella where the pregnancy-associated rate is going to be much higher than the pregnancy related rate. And that does get kind of important when we're comparing, you know, state to state and then state to, you know, to the nation in total. So we have pregnancy associated, we have pregnancy related, and then sometimes we don't really know where some of these deaths fall. You know, for example, if you have somebody who died by suicide, if they had, it gets a little tricky, right? Because you might have somebody who had depression before their pregnancy and they were okay. And then they maybe had some postpartum depression afterwards, and then they die by suicide in that year. It can be very hard sometimes to link whether the pregnancy made the depression worse and that ultimately led to that person's death. Domestic violence is also another tricky area, right? So if you had somebody who was in an abusive relationship before their pregnancy and I do have some experience working with domestic violence victims, you do see where pregnancy can exacerbate violence, right? Because you're introducing a new person that's going to be taking attention away from that abuser, and they feel very threatened by that. So, if the person dies in an event, a trauma related to domestic violence, it can be very hard to tease out sometimes if, the pregnancy, if it's pregnancy related, because it's hard to know if the pregnancy kind of tipped off the worsening of that situation. So it's not always really, really straightforward when we look at kind of counting some of these deaths. But ultimately, what we look at is, if states ask the question, if the person was not pregnant, would they have died? If the answer is yes, it's pregnancy associated. If it's no, it's pregnancy related. So I know that's kind of, in the weeds a little bit. Maternal mortality is reported as a rate. So you'll see a lot of numbers. It's reported as a number per 100,000 births. And in the United States, lost my screen here. sorry, I'm using a little screen to the side so I know what I'm talking about. And I'll get into, a little bit of the numbers a little bit later. So for the purposes of this discussion, we'll be talking mostly about pregnancy associated deaths, because you have people die, right? From a wide range of things when they're pregnant or in the postpartum area that are still really important, even if they're not directly related to the pregnancy. So maternal mortality is a really, really complex problem, right? But it's not a new problem. It's something that's been around, and we've seen it kind of, be really high for a while, and then it went down, and then we're seeing some more increases. So why are we talking about it now on such a widespread level, and why are we hearing so much about it recently? Does anybody know? Does anybody know? Like, remember in the past couple of years, one of the big things that came out? No, it's okay. So there was a series, it was a special series written by two journalists named Renee Montaigne and Nina Martin. They wrote a story in NPR and ProPublica in 2017. And it's a special series called Lost Mothers, Maternal Mortality in the United States. And it was a shocking feature. I remember I had been a nurse for a couple years, and I remember sitting on the couch and reading this series and just like sobbing, because it put words and it put experiences of people to what I'd been seeing as a nurse, and to seeing some of the problems that people were experiencing. And the story featured, the series featured stories of women in the United States who died from causes directly related to their pregnancies. And one of the major stories in there was about a woman, and her section was actually called "The Last Person You'd Expect to Die in Childbirth." And she was a New Jersey nurse who worked in a hospital in New Jersey, and she had a baby in her own hospital. She was a maternal child health nurse, and she had major complications after her delivery of her baby, and she had signs and symptoms that were overlooked and ignored, even though her husband and she were like asking, begging for help, because she really, really felt terrible. And she died, like right in front of her husband in the hospital. She died because they weren't taking her complaints seriously enough and kind of following through. And this was just one of dozens of stories that were featured in this article, or in this series of articles. And as it sort of caught fire, more and more people felt comfortable, talking about their stories. And we, like I said, this is not a new problem. That, New Jersey's been working on this for a while, but this just really took hold. And you had a lot of really good advocates start to come out and tell their stories, and to feel safe to share their stories about what not only happened to them, but to their loved ones. So the series, and a deluge of other series sparked a lot of outrage in the public, and it brought new attention to the problem of maternal mortality. It brought new scrutiny to the healthcare industry and to the surrounding structures that involved, maternal health care for women. It brought a new push for action, new laws, and it brought money, which is really, really good, because that means we can now do something about it, right? We had some landmark legislation that was passed in 2018 federally called the Preventing Maternal Deaths Act. And that was a big deal for funding things like state maternal mortality reviews. And it's really increased the ability of states to collect information so that they can make meaningful recommendations towards decreasing maternal death in their states. And the momentum has largely kept up, which is really, really encouraging. There's now a caucus called the Black Maternal Health Caucus, which is, chaired by Alma Adams and the nurse Lauren Underwood. And there's now a series of bills federally known as the Black Maternal Health Momnibus Act, which is co-sponsored by our own Senator Cory Booker, which is a series of 12 different bills, at least 12 different bills that address maternal health care in a variety of ways across the United States. So it's really exciting to kind of see some of this momentum not only happen on the federal level, but on the state level as well too. So I just want to get into the numbers kind of briefly. I don't want to take too much time away from Crystal. But I want to kind of just give some context for how much this happens, right? So every maternal death is a tragedy. We see about 700 women die every year as a result of pregnancy-related complications. 700 doesn't sound like a whole lot when you think of something in the past year, like we've seen, where we lose 550,000 people to coronavirus, right? But this is like this maternal mortality is just the tip of the iceberg, right? We might have 700 women die every year, but this is every year, adding on. And one thing we know is when we look at an iceberg, you only see the little piece up top. There's just this giant piece underneath. And we know that over 50,000 women every year suffer what we call near misses. So severe illness, injury, or complications that were caused by their pregnancies that almost killed them. All right. So major intervention had to take place in order to save these women's lives. So they might have had to have a hysterectomy because they were bleeding too much and we couldn't stop their bleeding. Or they might have been admitted to the ICU while they were in the hospital to, advance the level of care that they needed. They couldn't stay on a regular postpartum floor, or they needed massive blood transfusions to save their life, or they had a stroke because their blood pressure was too high. So, we lose hundreds of people, but there are tens of thousands of women who are suffering seriously every year when it comes to maternal mortality and what we call maternal morbidity, which is the illness, injury, and complications. Maternal death has a profound impact on our lives, even if we don't know it, even if we don't know somebody who died. Maternal mortality, it destroys families, it orphans children, and it desperately impacts the communities that we live in. Severe maternal morbidity, so if the woman survives, it can ruin somebody's fertility. They might never have children again. It might ruin their experiences that they never want to have children again. And it can leave women traumatized, seriously for the rest of their lives. So some of the things that we look at, are when does this happen in the course of pregnancy and postpartum? What do people die from, and how does New Jersey measure up? So here's what the numbers tell us. So when I talked a little bit about the number, per 100,000, the U.S. Pregnancy-related mortality rate is 17.4 per 100,000. Okay. However, it's not even statistically, and Crystal knows that, and Crystal's going to talk a little bit about that too. So we know that for white women, it's 14.7%, but for Black women, it's 14.7, not percent, 14.7 per 100,000, and 37.1 for Black women. All right. For Hispanic women, it's 11.8. New Jersey has a similar pregnancy-related mortality rate at about 14, but you hear New Jersey referred to, when they talk about New Jersey numbers, they talk a lot about the pregnancy-associated rate, which in New Jersey is a lot higher. It's about 47. So that's, I think, what they're referring to when they talk about our rank in terms of like states. So New Jersey is not too far off the nation, in terms of the related deaths women experience. But even so, New Jersey has very, very large differences in the pregnancy-related rates of death between Black women and white women. So in New Jersey, in the nation, you might have this rate where Black women die at 2 to 3 times the rate, but in New Jersey, it's like 5 to 6 times the rate of white women. And Black women do fare the worst when it comes to maternal death. Education and income are not protective factors for Black women, like we see for other women. And a Black woman who has good income and is college educated is still more likely to die than a high school educated white woman. So we really need to work on our disparities in New Jersey. So death can happen up to a year after delivery. Most people die in the postpartum period. So that's like in the week after they deliver to the year after their death. And they die of different things at different times. People die of different things during pregnancy than they die of on the day of delivery, and something very different than they might die from in the postpartum period. So in New Jersey, we see, most of our deaths come from cardiac issues. We also see a lot of blood clots. We see a lot of infection, strokes, and we see a lot of people who die from hemorrhage, from bleeding to death. We also see a lot of complications of blood pressure and preeclampsia in our state of New Jersey. There are racial differences in our the rates of death. White women die from different things from Black women. And one of the questions I always get is, why? Why is this happening? Why do people die? And when we look at it on like a large level and kind of look at all the different things, there's rarely ever just one cause, right? Like maternal mortality is a failure. The failures occur on many, many levels. All right. And one of the things that we really need to look at in New Jersey, is our rates of surgical delivery, right? That's an area that I'm interested in, is C-sections, because in New Jersey, we have very high rates of cesareans, and a lot of the deaths that we see can be tied back to, causes that are related to C-sections, hemorrhage, bleeding too much, infection, blood clots. Those can all be tied back to C-sections. So that's one of the things we really need to work on in Jersey. But it's a very complex problem. And like I said, it's not just one thing. And this is kind of where I'm going to get close to finishing. One of the things that's really important to understand is that health and wellness and illness, they don't live in a vacuum, right? Like it's not just you and what's going on in your body and genetics. We know that what we call the social determinants of health or social influences on health have a major role in how healthy we are, and they have a major role in how healthy women are and how they do in pregnancy and childbirth and in the postpartum period. So poverty, experiencing racism, access to a lot of different things really impact how well our health is. So access to equitable healthcare, healthy fresh food, transportation, affordable housing, clean air and water, affordable family leave and childcare, feelings of safety in our community. I mean, look at what we've been going through, even just, in the recent week where there's been, gun violence and hate crimes against people. The feelings of safety in the community impact how our stress levels are and how, that impacts our bodies. So all of these things, play a big role in our health. And if we don't address those, we're not going to be able to address the full spectrum of our health. So the good news is that maternal death is preventable. It can be highly preventable. What we've seen from reports from maternal mortality committees across the country is that they think up to 60% of deaths could have been prevented. And if you can learn why people are dying and find preventable cause of death, you're also going to really impact the numbers of women who are experiencing that, the morbidity, the injury, the illness, the sickness that can be caused by some of the pregnancy too. So I always like to think, as a healthcare provider who hopefully can have an impact on this issue, that there's things that we can do, that will help us prevent these deaths. From a healthcare perspective, as a healthcare worker, we really need to look at changing the narrative surrounding maternity care in our country. One of my favorite nurse scholars is a nurse researcher and clinician out of San Francisco. Her name's Monica McLemore, and she wrote an article called "To Prevent Women from Dying in Childbirth, First Stop Blaming Them. 2/3 of all maternal deaths are considered preventable. Racism, not race, is a critical factor." So we have to look at, we can't just go back to the idea that, women who are birthing are older or they're sicker or they're heavier. We have to look at external factors that are impacting their health and impacting our system's abilities to respond to that. And the medical world really has been trying to look at this for a long time now. In 2006, the Institute of Medicine put out a report that talked about medical errors and how 1.5 million people a year were injured by medication errors. and almost 100,000 people a year were dying of medical error. And medical error is one of the leading causes of death in America. And we've made a lot of strides since then, but we still have work to do. There's this Black midwife in Florida named Jenny Joseph, and she has talked about, she's really done a lot of innovative care for her patients. And she says, we have the resources, we have the review boards, we have the data, we even have the safety drills and protocols. We just don't seem to have the will. So we need to have the will, as healthcare providers and people to make improvements in the care. So I've talked a lot and I look forward to talking to some more, but I want to listen to Crystal now.
Thank you so much, Jamie, for level setting us tonight. The data that you heard right now is extremely important to the overall discussion about maternal health, especially right here in New Jersey. But additionally, we're going to jump into Black maternal health. And before we jump into my discussion, I want to share a video with you of the Irving family. Just one moment.
I hope you never have to read this letter. I cannot imagine you having to go through this yet again. And if you are, I am so truly sorry, Mommy. I hope you know how much I love you and how much you mean to me. I am sorry that I have left you. On the particular day that I am writing this, I have no idea how that may have occurred. But know that I would never choose to leave you. You will forever be my mommy, and I your baby girl. Shalon was my only daughter. She was loving, she was kind, she was generous. She was just always a curious child and loved to learn. She graduated from high school after skipping 2 grades. She went on to get her bachelor's at Hampton University. From there, she got a master's of science and then was accepted into a PhD program at Purdue University. She graduated with a dual PhD in both sociology and in gerontology, and she was the first student to do that at Purdue University. Both degrees were summa cum laude, and all by the age of 25. She went on to public health because she had watched her brother, who was battling MS, so she decided she'd go and get a master's of public health from Johns Hopkins, and then went on to become a well-respected epidemiologist at the Center for Disease Control. Unfortunately, her brother passed away, but she still devoted the work that she did at the CDC to her brother. Shalon was a very adventurous spirit, and we had traveled to over 20 countries in the last 5 years. She just loved life. When Shalon found out that she was pregnant, she was just overjoyed. She had wanted to be a mother for so long. She went to every single OB appointment. She did everything her obstetrician required of her. She had had fibroids removed probably a year before the pregnancy. And then she found out at the time that she had factor V Leiden. So she also had to take 2 painful shots every day to keep from clotting while she was carrying her baby. Well, based on her history, her medical team thought it was best that she have a planned C-section. She was prepared, she was ready, and she couldn't wait to meet the tiny human that she'd been sharing space with for 37 weeks. Shalon had tears in her eyes. She was so excited to see her daughter, and Shalon just held her. Within 4 or 5 days after getting home, she developed a lump on her side. She started having other symptoms as well, headaches. She wasn't voiding as she should have been. Her legs started to swell. She started to gain weight. She had headaches. And every time we'd go in to see a doctor, she was just dismissed with, "You just had a baby, give it time, it'll get better." And she says, "Mom, I don't feel right. There's something wrong." And I was just so concerned, but I didn't know what to do. During the last week of her life, Shalon went to the doctor 3 times for the same symptoms. On that last visit, she presented with blood pressure of 174 over 120. "Well, let me give you some blood pressure medicine and you go home and come back in a couple of days if it hasn't gotten better. But don't worry, it should be fine. Just give it a little more time." Well, after we left the doctor's office, we went and picked up her prescription and we came home. And so we were sitting there talking a little bit more, and all of a sudden, she started to have this gargled sound that came out of her mouth, and her arm shot up and she passed out. And I called 911. Probably 5 or 6 minutes later, the ambulance was there. When I got to the hospital, the emergency doctor told me that she was in pretty bad shape. I found out a couple of days later that she was brain dead because of the lack of oxygen. My cousin brought in a medical directive that I didn't even know Shalon had. And it said, "Mommy, I will fight hard, but if there is no hope, please let me go." And the next night, I happened to notice just one tear. It seemed like that came out of one eye. And I knew then what I had to do. We had her taken off life support. At 9:14, she was gone. I lost my vibrant, beautiful, intelligent best friend and daughter because she wasn't heard. I knew Shalon was a high-risk pregnancy because of her age, but I never for a moment thought that she was at risk of dying because she was a Black woman.
Wow. So what I'm going to discuss tonight are the disparities, the glaring disparities, and the many stories like Shalon's um, that really are ravaging Black mothers across our country and across the state of New Jersey. Um, as you heard from my bio, I've had a background in civil rights, but I came to this work particularly as a patient advocate. I'm a survivor of childbirth in New Jersey as a Black mother, an educated Black woman who had morbidity, maternal morbidity, resulting in preeclampsia, an unplanned emergency C-section, and a preterm daughter. Um, you know, what got me here was the fact that I didn't know pregnancies like that exist. When you grow up, we always talk about the beautiful things that, quite frankly, from what I now know, might be just the journey of many white women and not as many women who look like me. Um, you always hear, oh, when you're pregnant, you know, your skin is going to glow, your nails are going to grow, you're going to have the best hair you've had in your whole life, and everything is going to be roses. But that wasn't my experience. There's so many different things that come into play when we look at Black maternal health. And so I'm very thankful for the numbers and the data and the people, because that's what the data really is. The data are people, they're women, they're mothers. Um, specifically around Black maternal health. As we know, New Jersey does have its work cut out for them, or for us, right? Because I'm a lifelong New Jerseyan. But Black maternal health is going to require not just those who share a likeness to my physical features, but we need everybody to be on board with changing the narrative. And you can't change this particular narrative without talking about race. When I talk about my pregnancy class, I was in a class with Beyonce when she carried her twins and Serena Williams when she carried her daughter. And so both of them, Beyonce herself, preeclampsia, and Serena Williams experienced severe clotting. And fortunately, both of those women could advocate for themselves. And when you hear Serena talk about her particular experience, she had to advocate really, really hard to get the attention she needed for the symptoms she was experiencing, which quite frankly were life-threatening. And so I should always share that story, because by no means am I in the socioeconomic class of a Serena Williams or Beyonce Knowles Carter, but I experienced the same thing. So what is the common denominator? The common denominator is the color of our skin. And when we look at Black maternal health, as you saw the statistic at the end of the video, and Jamie had already given that statistic, our education and our socioeconomic levels don't protect us. When we talk about life and the pursuit of happiness and the American dream, usually those are the things that are supposed to shield us from having bad things happen to us. Go out and further your education, earn a good living, and you're going to be safe. Well, not when you're a Black woman birthing in this country. And so I'm very thankful for Senator Cory Booker for the Momnibus and supporting that legislation and co-sponsoring that legislation, because it is time to move the needle forward in Black maternal health. When we look back to the Civil Rights Act of 1964, within that mandate and in that legislation, there was a ban to allow any programs that receive federal funding to discriminate based on race, religion, culture, income. And it wasn't until 1965, when the Medicare-Medicaid Act was signed into law, did you really see the first challenge to see if that Civil Rights Act would be enforced. So what you saw initially were hospital settings were the first to have to embrace the federal funding and the non-discriminatory practices in theory. But at the same time, privatization in healthcare rose, which created what we have today, which is this healthcare system of the haves and have-nots. In order to really move this needle forward, we have to start looking at the social determinants of health. And when you look at the social determinants of health, like environment and education and housing, rather, nutrition, Black women, Black bodies, Black children literally are under attack from the cradle to the grave. And so one of the other organizations, as was mentioned, that I represent, Director of Black Health Equity for Salvation and Social Justice, we simply view healthcare to be a human right, because you cannot properly attack Black maternal health or Black healthcare inequities until you view everybody as human. Unfortunately, on the books, Black people are still listed as 3/5 of a person. So we have a lot of work to do in this very space. And so just to talk a little bit more about my particular journey in Black maternal health, I already shared I experienced a high-risk pregnancy. Initially, the high risk began simply because of my age. I was a geriatric birth. It's probably one of the more unflattering terms in medicine that you can tell a woman or birthing person, but it was what it was. And I was okay with that, because I waited a lifetime to have the dream of motherhood. And then things took a quick turn with regard to blood pressure, and things escalated. It was very touch and go getting to past that ultimate initial goal of the 12th week. And I can remember experiencing a time where I thought I lost my daughter in the middle of the night. And and she's here with us today, and that wasn't the case. At 35 weeks, I gave birth to a 4-pound, 1 ounce preemie baby girl who came in this world very much a fighter. She spent 3 days in NICU, and in fact, she was ready for discharge earlier than I was. She never needed breathing support. She never required any really special assistance. She had monitors on to just do just that, to monitor her. But she came in this world kicking and screaming, and apparently, you know, maybe 35 weeks obviously was early for me, but she let me know she could handle it really early on. But it wasn't enough for me. So I had to dig in and understand why. Why did I have the type of pregnancy that I had? That wasn't what I ever envisioned, um, outside of the geriatric name. I knew that was coming because I had not had a baby. And so I heard that that's the term. And I was aging. And so I knew that I couldn't get around that. But why couldn't I get around everything else? And so I began to research and dig, and I saw these horrific numbers for Black women birthing nationally and certainly within the state of New Jersey. And so from that, I learned about not only are the numbers terrible for maternal morbidity and mortality, but our preterm rate, our babies are dying. They're dying, you know, within the first year of life. Why? What is happening? Um, and I was concerned. I was concerned about despite how she came in this world kicking, what would her first year look like? What are some things? And I learned a couple of different statistics, and these can be found, I believe, with the March of Dimes website. Uh, Black baby girls do the best as preemies. They fare the best as preemies, followed by Black boys, Hispanics, uh, with an interesting statistic that white babies do the worst as preemies. And I said, wow, that's interesting because white babies are more often full term. And so um, I say that to say that Black babies, as I already stated, from the cradle, have to come into this world under the guise of survivorship, right? They come in early. They don't get the luxury, for lack of a better term, of coming in this world at full term. So there's always this set of odds stacked against us. And once again, when you look at all these different statistics and the numbers keep repeating that if you're Black, things aren't as positive. Point blank, period. And so I talked to other women, and I began Melanin and Motherhood. Number one, let me rewind. Melanin and Motherhood came about around my 20th week of pregnancy when I made it to the anatomy scan, and I realized I was so elated that I wanted to talk about my pregnancy because this was a great moment. The other reason why I created the platform was because at the same time, there had been so many ups and downs up to the 20th week, and things weren't seeming to change. Had I not made it on the other side of this, I wanted my daughter to see the journey, and I wanted her to know I tried my best. So Melanin and Motherhood was birthed as a love letter, as a diary to my daughter. And fortunately, I did see the other side of birthing. And so when we go back to all the research I began doing after, Melanin Motherhood then became a platform, an advocacy platform, an activism platform for Black maternal health. I do my best to sit at every single table where decisions are being made around maternal health care in the state of New Jersey, because it matters. It matters. We can't afford for it to be one more mother in this state, not one. And so when we look at Black maternal health and the experiences of Black women, I think it's so unfortunate that the woman lost her life here in the state of New Jersey that sparked all the articles. But her life had meaning and it had purpose because it created the dialogue that we are having today. And I'm so thankful for the other women advocates and other patient advocates and other family advocates who came out and said, enough's enough. This has to be a conversation, and there has to be change. And lo and behold, when you start seeing that change come about, you've heard so many similar stories. So with that being said, I also am very grateful for our First Lady, Tammy Murphy, and her initiative, Nurture New Jersey, which is, to strategically reduce these disparities in best case scenarios down to zero. But an area of concern for myself as a patient advocate is that the strategic plan that's been released is very comprehensive, but we have to take it all the way to the finish line, and we have to make sure that the changes that would then be implemented based on the strategic plan are not something that go away when the Murphy administration goes away, because these numbers have not been improving, and the numbers in New Jersey over the past 25 years continue to go in the wrong direction. In addition to the advocacy platform for melanin and motherhood, I'm elated to be able to share that in 2020, we began offering full service, full circle doula services through myself, because, thank you, Jamie. One of the things that I learned in my unofficial studies of Black maternal health and maternal health is that having a doula is something that can greatly reduce the numbers of mortality and morbidity and just unpleasant birthing experiences. So in my training as a doula, one of the things that we ultimately promote is a physiological birth. A physiological birth is free of any interventions. Sometimes the people use the term physiological and natural birth interchangeably, but they're not quite exactly the one and the same. And what's important about the promotion of an actual physiological birth is that what we know as doulas and as labor and delivery professionals is that the woman's body automatically and naturally knows how to give birth. And so when you have a doula present, and just want to share some of the benefits of doulas, when you have a doula present, you're less likely to have outside interventions, many interventions that are simply really unnecessary. But unfortunately, the culture and the society we live in have normalized these interventions because we live in a society where we look for things to be immediate and easy. And everything is not going to be immediate and easy. And so many women electively select cesarean that are not medically necessary, right? Even Pitocin, those things are not necessary, and quite frankly, don't always help in the way that one should expect it. Pitocin is a synthetic form of the natural hormone oxytocin. We get oxytocin, it's the love hormone, right? It's the pleasure bug. There are a lot of ways, and we're all adults on here. That's why sometimes at the end of pregnancy, you'll hear an OB say, go home, make love. That helps speed things along because that's the oxytocin. Pitocin is synthetic. Pitocin is man-made, and Pitocin, you don't even know how the body's going to respond. So many women subject themselves to Pitocin thinking they're getting an intervention that helps. A lot of times Pitocin will make your contractions a lot stronger than they would in a physiological birth. And they can actually extend the time that you're in labor. A lot of times we see in hospital settings that doctors don't want to allow a woman to labor more than 24 hours. Well, for first-time births, labor and delivery on average can be about 24 to 48 hours. And so as a doula, we always encourage our clients to labor at home as long as possible, because once you enter the hospital setting, you're going to be, let's say, enticed or offered these various interventions that your body does not need. Now, I know that we hear a lot of things about C-sections in the negative. Let me be clear and recognize that there are medical needs for cesareans. But even in those situations, that means the cesarean, the benefits have to outweigh the danger that you're already in, okay? Because once you start opening yourself up to a C-section, you're having major surgery. Women are, some birthing people tend to worry about what's going to happen down there if I do this the old-fashioned way, not recognizing that your body is under so much trauma from carrying that child, from making that life, that introducing unnecessary interventions can turn into something that is absolutely fatal. One of the last areas that I'll talk about, and I want to open us up for Q&A, Nancy, is the fourth trimester. Jamie touched on it, but I want to go into the fourth trimester just a little further. The fourth trimester is after birth. One of the things as a doula we definitely always encourage is skin-to-skin contact when possible, immediately after birth. You know, especially, well, in all cases, but even in the case of a C-section, a lot of women think that they can't experience any kind of skin-to-skin, and that's not true. You can demand it, you can request it, and quite frankly, any hospital setting with good bedside manner should actually encourage it, because your body will begin to relax, and that's very much helpful while you're on that surgical table as you get ready to go into recovery. But the postpartum is it goes so much further than that. As we said, when we look at mortality rates, we include deaths up to the first year after giving birth. When we look at that fourth trimester, I literally include the fourth trimester to go up until that 1 year after giving birth. We have to, as women and birthing people, have to make sure that we're taking the time to allow our bodies to heal. Having a doula is a wonderful thing. My doula happened to be my mother. She's not a trained doula, but she was my doula. And what has to happen is that what we see, well, I want to go back to social determinants of health just really quickly and how we can tie this into the fourth quarter. When we look at the social determinants of housing, nutrition, right? Those things require you to work and to have income to have your housing and nutrition. Many Black people, Black women, it's like we said, it's not socioeconomically based, but there are different, obviously there's different professions. So if you're someone who works some form of frontline position, or if you're in a fast food setting and you don't have a great deal or a great length of time for maternity disability, you find yourself back to work long before your body has had adequate time to heal, right? And so the risk factors go up. The same can be whether you're, in a career that is an office setting, whether you're an accountant or a physician or anything. The postpartum period has to be taken seriously. We tend to want to jump right back into the movement of life. But what people don't realize, and what women don't realize, is that, or what they're not thinking of, is when after a baby's born and the placenta comes out, and you look at the size of a placenta, that literally represents the size of the gaping wound in your body that is trying to heal. And when we overdo it too soon, you rip the scab off and you're bleeding again. And so postpartum care is just as critical as prenatal care. And in one place that we haven't done well, and New Jersey is doing things to improve this, thankfully, is extending the type of postpartum care you're getting as far as your healthcare coverage. We have to get beyond just the 6-week visit. We have to start looking at models that include postpartum care, literally going up to that whole year. Many births in New Jersey are Medicaid births, and the Medicaid births do not, up to this time, we're not covering postpartum care in the way that it needs to be covered. In other countries, the United States, as Jamie says, the most dangerous place to give birth in a modernized civilization. However, you look at other countries like Canada and France, you are automatically essentially given a doula or someone who comes to your home for an entire year. Maternity leave is an entire year. What an interesting point to discuss on Equal Pay Day, Women's Equal Pay Day, right? These are all things that factor into maternal health and Black maternal health. When you look at the fact that the disparities in the wages that Black women are paid, we're out here, we're working hard. We're working harder to catch up from a financial standpoint. We also deal with the trauma of just trying to be heard and be seen in our various careers and positions, right? That's the stress that comes with the color of our skin. That's the common denominator in everything that we see go wrong in Black maternal health. The other piece that we have to address are antiquated textbooks that spread essentially lies with respect to race and pain. There's a textbook out there, I can't remember the name of it right now, that literally teaches med students that Black people have thicker skin and higher levels of tolerance for pain. And this is something that we see get carried into medical and healthcare spaces all the time. And just like this in Shalon's story, as we heard, many other stories that I could share of various different women, and even in my own time in the hospital, when I said that I experienced something, I was not heard. When Serena Williams said she was experiencing pain, she was not heard. And so we have to walk Black maternal health and maternal health all the way back to the books, right? To our medical students. So we have to go back to med school, right? To take some of this deadly information out of curriculums, and we have to start looking at accountability measures for those who are already in practice. And so with that, I will probably go ahead and close this out so we can have time for question and answer. But I will say I'm a very, very proud Black doula. I'm a proud Black birth worker. And I'm elated to be here, not only on Women's Equal Pay Day, but during the International World Doula Week 2021. Yes. So we have a lot to celebrate, and what I'm very happy to say is that there has been a tremendous increase in Black doulas, because we're recognizing that we need to have that type of support in our birthing spaces. And so with that, I will wrap up my comments. I'm sure anything I missed may come out in a question, but I'm really happy to be here and just to talk about Black maternal health in New Jersey. If anybody tells you that it is not race-based, you tell them they're not ready for this moment. Black maternal health disparities are race-based, and they're race-based on treatment by people who are not ready for the moment, who do not want to relinquish ideology that is not only false, but proven to be deadly. We cannot change Black maternal health in this nation without talking about race, period. So with that, thank you for having me. And I can go to questions and answers.
Thank you so much, Crystal. I'm sorry.
Would I be able to add, can I add two things to what you said, Crystal?
Absolutely.
Okay. First of all, number one, every woman deserves a doula, period. Every woman deserves a doula. And doulas are just fantastic. And especially in the postpartum period, like you were saying, where we see most women die, like they go home, they don't see a doctor for weeks or a midwife or whatever. And doulas can really, really bridge that gap and say, hey, look, you don't look so hot. Why don't you, make some phone calls, or why don't I help facilitate you, being seen? So every woman deserves a doula. And I thank you for, serving our community, in that regard, and taking your experiences and putting it into action. The other thing I was going to say about was cesarean delivery, because I watched this really great webinar the other day by one of my favorite obstetricians who likes to talk about C-sections. And he said that since the 70s, I actually wrote this down. He said, since the 70s, there's been a 500% increase in the use of surgical delivery and the use of C-sections, with no demonstrable improvement in outcomes for babies. And our maternal mortality rate for moms has increased by 50%. So it's really shocking when we look at the relationship between the increase in our, cesarean deliveries with the increased maternal mortality rate for women. And like you said, you're not advocating for no C-sections. No credible person who talks about these issues advocates for 0 C-sections. We don't know what the right rate is. We think it might be somewhere between like 15 and 19%. And what a lot of hospitals are doing now is not only looking at their C-section rate, but looking at the what they call balancing measures. So if they get their C-section rate to a low point, are they seeing increases in, neonatal or babies being born with problems, or, did they wait too long? So nobody wants to advocate for no C-sections. I think what, you and I, want to make sure of is that the right C-sections are being done on the right people at the right time, right? To make sure that when they're done, and I'm speaking as a 2-time C-section mama, we want to make sure that the people who are getting them are the people who need them, and that they're done safely, because not only do they impact your first C-section, but 90% of moms who have had a C-section, when they want to have another baby, they have another one. We have a low rate of what they call, trials of labor after cesarean, or vaginal birth after C-section. And you can see major complications that come from second C-sections and third C-sections and 4 C-sections. This doctor that I was referring to, he says that when you are operating on somebody who's had, 3 C-sections, it's like operating on a melted box of crayons. It's really dangerous because, things just start to melt together inside. They adhere to each other. So it can increase the morbidity and mortality rate the more surgical births that we have, and it is major abdominal surgery. So I think we're getting better at that in New Jersey. The C-section rate I just saw for 2019 nationwide came down by like 0.1%, which is, it's really hard to move that needle. But New Jersey in the past couple of years has reduced their overall C-section rate of preventable C-sections by like more than 5%. So I think we're heading in the right direction in that regard, even though we do have a lot of work to do. So thank you so much for everything that you talked about.
Thank you. And, I just wanted to say one other thing. I'm fortunately, I'm mentored by, my mentorship has taught me that you cannot go into birthing spaces as a doula and be shy. There are different models, or different people go in there with these different ideas that a doula is supposed to be your advocate. I do my advocacy on my advocacy platform, but quite frankly, a doula should help you to be empowered to go in and have the birthing experience that you seek. And my mentor, Michelle Gabriel, many people probably have, if you know anything about doulas, she's probably one of the top doulas in the state of New Jersey and in the country. She was just featured in the New York Times. And she is a tremendous stickler on that postpartum period, where she has a rule of 10-10-10. First 10 days, you don't even get out of the bed. The second 10 days, you get out of bed for 30 minutes tops for the whole day. And then the third 10 days, you can get out of bed for a couple hours. But at every point, you're supported. So that's where that kind of postpartum doula comes into play. And one of the things that a lot of people tend to think is that a doula is based on, unfortunately, a lot of insurance companies do not, private insurance companies do not cover doulas. But I just wanted to just alert everyone to other resources. Now you're starting to see things like community doulas. Um, and these community doulas are collaboratives of doulas that get reimbursed through Medicaid, which is another nod to the Murphy administration for now being able to get doulas reimbursed through the Medicaid system. And so those who may not have additional supports are now being afforded the opportunity to have additional supports. And so just like Jamie said, every woman deserves a doula. Now we're really working to see every woman getting one. And so just know that there are a tremendous number of resources out there at this time across the state to get doulas. In fact, New Jersey did a pilot program 2 years ago of to train Black women as doulas, right? And so they used the hardest hit areas in the state of New Jersey. So you have Essex County, Atlantic City, which has the worst preterm birth rate in the state of New Jersey, and Mercer County. And they all had these sessions of training through the Uzazi Village, which is a wonderful curriculum training Black doulas. And there's a great deal of cultural competence in that particular doula training. And they have trained over, gosh, I can't remember the exact number, but at least maybe over like 60 or more doulas across those 3 counties. And they all have community doulas in their areas. And what we're looking to see and hope that we're pushing for is that you'll see that type of resource in every county in New Jersey.
Yeah. That sounds great. Thank you so much, Crystal and Jamie. This has been a great conversation, really informative. And I really hope that we can all be diligent and pay attention now and make sure that these legislations take place and stay maintained and improve.
Absolutely. One of my biggest pet peeves is unfunded mandates, right?
It's ours too.
Unfunded mandates are nothing but rhetoric.
Yeah.
Mm-hmm.
So, you can tell a lot about a state where they put their money at in their budget.
Mm-hmm.
And seeing more dollars going towards maternal health is a huge plus, but we need to continue to see more dollars going into maternal health.
Mm-hmm.
And the legislative piece is critical because, as I said, we don't want to see these things go away when the Murphy administration goes away and all of a sudden the money goes away. Because, as I said, we talk about data, but in this particular case, every piece of the data is a person, it's a life, it's a mother. Yes. And so we want to make sure that we're out there fighting for legislation that is lasting, sustainable change in the right direction for maternal health in New Jersey.
Mm-hmm. The interesting thing about some of the things you guys just discussed is that, there are so many grassroots agencies too that are already, and I think we talked about this a little bit last night, that are already doing this work, right? Like it's awesome to get new funding and new, new legislation. And there are a lot of, maternal mortality is not a new issue in New Jersey. We have one of the oldest maternal mortality review committees in the nation. And we have a lot of agencies that have been working for decades on this issue. And I think as, people who, might want to do something, I think it's really important for us to be able to maybe look at where we put our, philanthropy as people too, and say, what can I do? Well, guess what we can do? Like you can find an agency or you can, find somebody that's doing the work that you can relate to, that's important to you, and, and use what you might want to donate to them, because, instead of recreating the wheel, right? There's already people out there that are doing the work, especially, in the Black community. There's a lot of agencies that have been doing this work for a long time because they knew that there was a need, right? So it's one way that we can support the community is to, through our own personal or private philanthropy as well.
Yeah, and I've seen it firsthand that, the more of these grassroots groups put enough pressure on the government, it helps. It helps every bit. So, yes, we should all be voting. We should all be registered. We should all be voting and make sure that our government represents us as women. But yeah, I mean, participate in these grassroots organizations, get your voice heard. It's really important and it helps. I'm really excited that you ladies were here.
I just want to throw one other quick piece out there. You probably hear a lot going around about the Reproductive Freedom Act right now. And so oftentimes one of the alarms that I tend to ring is that you'll see a lot of focus around abortion rights when you hear about reproductive justice. But when you look at maternal health, you make sure you're including reproductive justice in that conversation. When you talk about Reproductive Freedom Act, you need to make sure that you're seeing things in there that surround changes around maternal health, because it's defined as having children or not having children, or the ability to raise your children. So that's just one thing. I know right now there's a big push on that Reproductive Freedom Act. Know that in there we have expectations regarding maternal health as well. It's not solely focused on abortion, which many people think, and then they kind of don't want to. A lot of people don't necessarily want to take sides on the abortion issue, but reproductive justice includes access to birth control, maternal health, Black maternal health, obviously, and all sorts of other disparities when it comes to reproduction. So this one.
Thanks, Crystal. Anyone have any questions or comments?
Informative, I have to say. You really provided a lot of information, a lot I never thought about. So thanks both.
Thank you. It's really shocking. It's really shocking, even as as a nurse. I think I talked about this the first, when I was at your meeting last week, and Marianne asked me, how did you get into this? And I said, for me, it was the first time I ever saw a woman almost bleed to death in childbirth was on my 5th day of work. I was on orientation. I wasn't even my 2nd week. And she had a really complicated delivery, and she was, family was holding her baby at her feet, and she was practically bleeding out, and they had no clue. And we knew stuff was happening. And, I was under the care of a wonderful, wonderful preceptor at the time who was training me, and she knew everything to do, and she jumped into action, and, everything turned out okay. But I just stood there like a deer in headlights because I had no idea what to do.
Yeah.
And it was it was an awful feeling. And I went home that night and I called my sister. My sister is a obstetrician. She's a high risk OB. So you can imagine we have some really interesting dinner table conversations. And I said to her, told her just, a little bit about what I saw. And she said, Jamie, she said, our job is to prevent maternal mortality. And I said, I'm like, what? I said, what are you talking about? I said, that doesn't happen here in the United States. I'm like, oh, maybe that's your job sometimes, but my job is to help babies be born and, swaddle them up and maybe get a quick snuggle and hand them back over to mama, right? She's like, no. So, from that very day, I was just captivated by what was happening, in healthcare and in our country. And I wanted to learn as much as I could to try and, move the needle and impact that. But it's really shocking when you think, how big our healthcare system is, that we can still be experiencing so many problems and losing so many mothers to something that is so preventable and devastating.
I think Jamie and I need to take this on the road, because
I think so too. I want to have a delivery. I want to have some birth. I want to have some babies with Crystal.
Yeah.
I'll tell you, I'm thinking to myself, man, I wish I had Jamie, but I had my daughter.
I see a partnership in the future.
This has been a really great conversation. And I wanted to say, as a former high school teacher and now college teacher, On the front end of this, it should be the teaching in high school and even in middle school in
Yeah,
terms of
yeah, that's true.
sexuality and sex education should really be totally renovated and
Yes.
inclusive in terms of teaching people about their bodies, how
Yeah.
to use them, and that might help to prevent some of these losses, terrible
Absolutely,
losses.
Roberta.
I just want to say that the information was very informative. And
Yeah.
as a mother who delivered both her children by cesarean section, with my daughter, she wasn't moving in the right way. She was about to go head first. So, I'm sorry, she was about to go the other way first. So I had a cesarean section with her. And then when my son was born, they informed me, which I later learned that not necessarily, but they said that because she was born by a C-section, then my son automatically should be birthed by C-section. So I had the 2 C-section. The other comment I want to make is about Congresswoman Alma Adams. My sorority had her last week. She came and talked about HBCU funding. That woman is dynamic. She's awesome. She has her hands on a lot of stuff. And you know, just listening to her speak, although she spoke to us about funding for HBCU colleges and universities, but as you were speaking, Jamie, I Googled her because she didn't speak on maternal health when she came. But I was just glancing through some of the stuff. She's really involved in a lot of stuff. Yeah.
Mm-hmm. You know, and it's funny that you bring up, you know, the HBCU funding. I think as a nurse, you know, I really want to see diversification of our workforce, right?
Yeah.
Like a very low percentage of our workforce looks like the people that we serve, and we really need to have, you know, more Black nurses and more, you know, Black OBs and more Black midwives and other, you know, women of color as well, and people of color. We really need the workforce to reflect the people that they serve, and they have been able to show, at least with like fetal, you know, and infant outcomes. There was a recent study that came out that said Black babies do better when they're cared for by Black doctors. And I don't know that has really translated on the maternal side yet. But it's like really shocking to hear that. So I think we really need to, number one, I think we need to kind of figure out why that's happening. But we really need like funding and promotion of students, you know, not only medical students, but nursing students, midwifery students, you know, to be able to support, you know, and to be able to not only get those students in the pipeline, but to support them so they can make it through to practice, because I think that'll make a big difference as well.
So I read someplace though that as it relates to Black patients, that when Black patients complain about pain or having difficulty, that sometimes white doctors do not listen to them. And I specifically focused in on the video that you showed, Crystal, which bears out a couple articles that I read previously.
It's really a shame. It's a tragedy. And like I said, some of it literally goes back to textbook teaching, though.
Yeah.
You know, and that's like I said, it's just it's a deadly lesson. Like that particular book renders a deadly lesson. And I know for me, I had a great OB, and I overall had a great birthing experience. I spent 5 days in the hospital when I had my daughter, maybe 6. And I remember the one night I developed pain in my leg, and it really was becoming concerning that I was having clotting.
Yeah.
And the nurses would not respond. Like, they're like, oh, you know, you just, you know, maybe haven't got out of bed enough or whatever. They were saying little things. And my mom was there and my husband was there. And Ms. Holly knows my mother, so she knows I had a really good doula there.
Oh yeah, absolutely.
And she was like, I could see that it was becoming a concern to her. And I said to that, finally, I had to say, after calling several times, can you look at it? To the point where initially they wouldn't even check it, like to feel the leg, right?
Mm.
When I finally said, listen, I know my doctor's on call in the hospital this week. So if you don't call her in here, I'm going to call the on-call from my cell phone. I'm going to call the on-call line and tell them that I'm here, right here in this hospital, and that I need care. But everybody is not going to like that, right? And it wasn't until I made that threat, then I start getting an exam, and they start me out.
Ruling it out.
Crazy.
Yeah, and to add to that, and to add to what Ms. Holly said too, there was a CDC. The CDC had to create a whole campaign called "Hear Her."
Yeah.
So you can actually Google it. CDC is called the Hear Her campaign, and it's all about not only teaching healthcare providers to take a moment and listen to your patients. It also talks about like family members, right? So some of the biggest problems that we have with maternal death and severe maternal morbidity is when the patient goes home, right? So if you have maybe like a family member who kind of like explains things away a little bit or poo-poos a little bit, they're like, oh, I'm sure you're fine. Oh, I'm sure you're fine. We need them to not do that, right? We need them to hear you. Thank you for putting that up. And to hear your concern and to advocate for you to get care, right? So we need our family members, our patients' mothers, our patients' partners and spouses to, really hear what you're saying when you're saying, you know what, I just don't feel right. Because moms know, like, they don't know, they might not know what's wrong, but they know something is wrong. And we need to listen to them in order to, try and, fix some of this preventable mortality.
I appreciate you ladies being here. I really do. And this was an excellent conversation. It really was. I'm so excited that you came. And, I think about, what I went through. I can't even imagine, the level of the difference, and I kind of, I didn't have a great birthing experience my first time around. I had a crappy nurse and who didn't listen and things like that. But then just adding on to that is, I just can't even imagine. And my heart goes out to you, and I want to see all of that change. So whatever we can do.
When we have good people like you who are, and all of you who care about this enough to come out and listen and learn more and advocate for change and advocate for the families in our state, it gives me a lot of hope that we really can make things better for the families we take care of.
Absolutely.
Thank you. If everybody's good, I think we'll call it a night. But thank you both so much for being here.
Thank you so much. This was really great.
Here.
Yes.
Roberta,
I really appreciate it. It's a great conversation.
Great. Have a good night.
Thanks for your amazing work, Crystal.
Thank you for yours as well.
All right, guys.
Take care.
Yeah, I know, right? Okay. Take care, guys.
Bye-bye.
Thanks.